Good afternoon, dear audience. Let me show you my one-year progress on my PhD topic, Advanced Strategies in Improving Outcomes During Mechanical Ventilation. My name is Csenge Szigetváry. I'm working at the Department of Anesthesiology and Intensive Therapy. And with our team, our vision is to implement more personalized strategies in intensive care medicine. I've been working on 6 projects during this whole 1 year. And the first one is entitled Individualized Positive End-expiratory Pressure Settings Reduce the Incidence of Postoperative Pulmonary Complications. This is a systematic review and meta-analysis. The importance of this topic is that when someone undergoes general anesthesia, due to the anesthetics and the muscle relaxants and the position changes, the diaphragm and other respiratory muscles lose their tone, and this will lead to a progressive atelectasis during the surgery, deteriorating the oxygenation parameters and may also lead to postoperative complications. In order to prevent that, we use positive end-expiratory pressure, PEEP for short, to keep the alveoli open. Therefore, we can improve the oxygenation, but higher levels of PEEP may be inappropriately high and cause overdistension in the lung tissue, leading to more complications. Therefore, we want to find the most optimal PEEP for the individual patient, that is in the green area, and we want to do that to reduce the postoperative complications, but still provide a better oxygenation during the surgery. So our question was whether the personalized titrated PEEP results in better perioperative parameters outcomes in patients undergoing abdominal surgery. And our primary outcome was the incidence of postoperative pulmonary complications. We have found 17 eligible randomized controlled trials that examined this topic, and I would like to show the results. First of all, the individualized PEEP, we found that it was significantly higher than the conventional fixed PEEP settings. It was about 6 centimeters of water higher. As the primary outcome, postoperative pulmonary complications, we detected a significantly lower odds of receiving postoperative pulmonary complications when the patients were ventilated with individually set PEEP. As the detection of oxygenation, the PF ratio is a good monitoring parameter. It's the fraction of inspired oxygen under the pressure of arterial oxygen. The higher this ratio is, the better the oxygenation status is. We found that at the end of the surgery, those who were in the individually titrated group had a significantly higher ratio of this parameter, and this suggested a significantly better oxygenation status. Regarding the hemodynamic status, we saw a tendency that if someone was in the fixedly titrated PEEP group, they had a higher chance of not receiving as much vasopressor as those who were in the individually titrated group. Therefore, this method, the intervention method, may lead to hemodynamic worsening, but our results were not significant. Regarding the respiratory mechanics, we measured both dynamic and static compliance, and they were both significantly better in the individually titrated group. As a conclusion, we can say that the individually titrated PEEP were nearly 6 centimeters of water higher on average. This is a very significant difference. And this intervention reduced the incidence of postoperative pulmonary complications. It led to better perioperative oxygenation and better lung mechanics. But we have to consider a higher chance of developing hemodynamic instability when we use this individually titrated PEEP in our patients. As a summary, as strengths, I would like to highlight that we only included randomized controlled trials, and to our knowledge to this date, this is the first meta-analysis that investigates this titration method on patients undergoing abdominal surgery. As limitations, I would like to mention the heterogeneity of both our populations, both the interventions, because the PEEP was titrated with different methods, and as well as the comparator were different PEEP levels. As the outcomes, they were measured at different time points. And based on that, the implication of our research would be to perform more studies on a more homogeneous population and more homogeneous study design, as I mentioned. The clinical implication would be to improve oxygenation and reduce the postoperative pulmonary complications by choosing the individually titrated PEEP on the patients. Currently, we are finishing the manuscript draft, and we are going to send it to internal review within the month. My second project is an initiation of a registry on acute hypoxemic respiratory failure. This is an important topic because it is the leading cause of need of admission to the ICUs, and it is associated with a very high rate of mortality. And currently, we don't have registries on this topic, neither in critical care in general, and neither on this topic in our country and in Eastern Europe. And we would like to collect high-quality data on standards of care, on procedures, and on this acute hypoxemic respiratory failure patients in order to improve their outcomes. We have our registry resources. We are going to start this registry in Flor Ferenc Hospital, and we have already defined our eligibility criteria for the registry, and we are currently in the ethical approval requesting phase. My third project is hemoadsorption as adjuvant therapy in acute respiratory distress syndrome. This is also a systematic review and meta-analysis. ARDS is usually a secondary result of a dysregulated inflammatory host response, and this is why immunomodulation by removing the cytokines may be beneficial for these patients. And our question was whether those who undergo hemoadsorption therapy have a better before and after parameters regarding oxygenation and ventilator-free days. These are our primary outcomes. We have some preliminary results, and we have submitted our abstract to a conference, and we found a few outcomes: the PF ratio, the noradrenaline requirement, and the postoperative CRP to be better after this hemoadsorption therapy were used. So these were the three projects I've been working on, and I would like to thank for all the help in this 1 year and your attention. Thank you.
You mentioned in your lecture there are a lot of different methods, PEEP, titration method. What kind of methods do you know or explain a few?
So, as I mentioned, we don't want to cause harm to the lung. And mechanical ventilation is not a physiological thing. So what we want to avoid is...
But how can you titrate the PEEP?
We want to target an ideal parameters measured by the ventilator that suggest that we are not causing harm to the lung. That's one. So titrating to a parameter, or using some bedside diagnostics such as lung ultrasound or a machine called electrical impedance tomograph. These visualized diagnostic tools can give us an impression of the ratios of the ventilated and overdistended and closed areas of the lung. So,
Thank you.